Yes, thanks a lot. Now it's a little bit talking about the corpus callosum in the setting of malformations. I would like to do three simple things here. I would like to talk about obvious facts, things we all know, then not so obvious facts, which we should be familiar with, and that is a little bit an excursion to basic neuroscience. And another part is things which are no facts yet. They are no scientific facts yet, but still I find them interesting and roads to pursue. This is what I have shown already in the past, and I think it's important. It's something we have to keep in mind as a really important fact, and that is that the corpus callosum is just a sign of something what happens within the brain. And why is that? Because the corpus callosum is a three-dimensional structure. It's connected to many parts of the brain and represents basically neuronal and axonal and white matter processes, and therefore also changes in those structures. Now, in fetal MRI, this is nicely visualizable with DTI, and you can see that many brain regions are connected in a certain way. I would like to start off with this case. This was a case with thin corpus callosum and mild ventriculomegaly at 22 gestational weeks. You can see that on neurosonography, the corpus callosum was slightly thin. Then on MRI, we could kind of confirm that and could visualize that as well. We have a thin corpus callosum, but we also do have an aqueductal stenosis. We have a vermian tail. This is a very interesting constellation, normal positioned vermis with vermian tail. I think this will give us some headache in the future. And we have a hypoplastic corpus callosum, thin corpus callosum in this case. What we also have is we have abnormal crossroad signs. And you remember probably that Daniela has been talking about that now for about 20 years, but I think it's still important because the combination of all that is important to basically put together and think about this case. Now, crossroads are landmarks of axonal growth. There are multiple crossroads in our brain. It's just sites where different fibers are intermingling, and here in the frontal lobe or here in the parietal area. And these parietal crossroads can be changed in their signal, and when many fibers contain a pathological information, such as in this case of an AP4B1 mutation, which goes along with an axonal abnormality on axonal transport, it's clear that in these zones of these crossroads, you will get some signal abnormality. So the thin corpus callosum, the crossroads taken together are just a sign, an indicator that something globally goes wrong in that brain. And the AP4B1 mutation causes hereditary spastic paraplegia, which is not a brain malformation per se, but it's a genetic disorder. And currently, people at Boston Children's are working on a gene therapy, which might be even at some point be used prenatally. I really want to convince you that it's not about the numbers of connections you have in the midline, it's about the quality. And if some of those connections are slow, you can run into a problem. So please remember, it's always quality over quantity. When we're looking at brains, and this was a perfect example, and that's also something I learned from Daniela, is many problems we are kind of dealing with in fetal neuroimaging are peak of the iceberg problems. We are seeing just a very, very tiny part of what's really going on. The bigger part is often invisible. Now, the more advanced your imaging technology, the more you can see on the outside and say something about it, or you can take a deeper dive and try to get really a whole picture. And that's what we are basically doing here, I think. For that, it's important to understand that the corpus callosum is not only a connection in the midline, it contains fibers where neurons are topically connected, meaning that one neuron in the right hemisphere connects to the exact other neuron of the other hemisphere, and that's true for other neurons as well. However, there are also heterotopic connections, meaning that some of those neurons are connecting to others, not to their same counterpart in the other hemisphere. Now, the interesting thing about our brain is that the majority in a healthy brain of our connections in the corpus callosum are heterotopic. So it's not same, it's same with a different neuron. So it's a mixture. And basically, if you have a callosal abnormality, the ratio between heterotopic connections and homotopic goes up, meaning the quality of those connections has somehow changed as well. In agenesis of corpus callosum, this is basically the most extreme form. You have the Probst bundle as a fulminant maximum of heterotopic connections. Beside those, you can do connectome research, and you will find many others of heterotopic connections which are not only belonging to the corpus callosum in many of those cases. So the bundle of Probst is probably not the only misguided pathway in many forms of callosal agenesis. This leads to conformational changes of the brain, which means the missing corpus callosum goes along with other different connections which are not supposed to be there in a normal brain, and the entire brain changes. And what you see here is the cumulative view of 33 cases with complete callosal agenesis, and those areas of the brain which are different compared to a normal brain. And you see they are particularly pronounced in the postcentral, parietal, and occipital lobes. Whereas there is a thickening in the frontal and frontomesial parts. That's very comprehensible because this is the region of the Probst bundle. Now we know these acallosal brains are different. The question is, how much are they different? We also know there are homotopic, heterotopic connections, and we can use tractography to dissect them here. If we remove the corticospinal tracts and the Probst bundles or the sigmoid bundles here, we are left with the Probst bundle and the fornix. So we can dissect the situation of this partial agenesis here very nicely. Do we know the outcome? No, not at all. This is the outcome. Konstantin is now more than 6 years old and he's doing absolutely perfect. So it's not about the numbers of connections we have here in this partial callosal remnant. It's about how those connections are used and what is the underlying genetic program which is basically guiding them. This is a case from Gustavo where he brilliantly found this circumscribed thickening of the anterior corpus callosum, and here the tractography we had a chance to do, and you see how many heterotopic connections are exactly happening in this circumscribed region. Did that do anything? No. This was a normally developing fetus, and I can show you a case which I recently came across. This is, as you can see by the missing teeth of this gentleman, an 80-year-old person with just a really awkwardly looking corpus callosum doing perfectly fine, except of his vascular problems he was recently developing. Again, quality over quantity. And a pinnacle of that is the fetal alcohol syndrome. If you look at animal studies, and we had a chance to conduct a study with the group in Marseille, where they exposed fetal rats to alcohol, this is how the corpus callosum and the fibers there are normally organized in a coronal view with light sheet microscopy. Now, if you if you look at the corpus callosum after alcohol exposure, you see how disturbed, how weird this structure is. Again, the quality of those fibers has changed significantly, and we had the chance to prove that also in our cohort, where we found structural differences in otherwise normal-looking brains of cases with alcohol exposure. This also explains that there is not a single neurological abnormality. There is a multitude of problems, but we will hear about that later as well. Now, coming back to this concept of peak of the iceberg exploration, I think it's always important to keep everything in our view. It's not that one thing is less important than the other, and for that reason we are developing these connectomes, which look at different phenotypic features which can co-occur more frequently here in isolated callosal agenesis, but which can help us to generate prognostic scores, for instance. This is now the newest data on that score. Isolated cases are usually characterized by hippocampal abnormalities and colpocephaly. This is part of the spectrum, whereas associated cases have often a multitude of different anomalies and therefore score higher in this score. So a way to really look at the entire iceberg in a more comprehensive and structured fashion. I give you an example. This was a case referred to us by Ravi Shao. He did ultrasound and found that the posterior fossa was wide. He found ventriculomegaly, but he had a weird feeling and had said, well, the whole exome was negative. What's going on here? Now, we did the MRI. We had confirmed his findings. In addition, we felt that the corpus callosum was quite thin here, and the hippocampi were abnormally positioned. And we had this really wide posterior fossa with a rather small vermis and this thin corpus callosum. Of course, we did tractography, but I can tell you tractography didn't tell us anything here, just showed some nice midline fibers. This was not a solution to the clue. The solution was that we told Ravi, look, this is not only mild ventriculomegaly, there is a series of soft markers you and we were able to see and were abnormal, so that the entire iceberg was more deeply characterized. And then we also found, with the help of ChatGPT, that there are similar sort of constellations, thin corpus callosum, wide posterior fossa, compressed vermis, and suddenly we found that gene, which was called DAT-POX gene, which is an histone organization gene, very deep in our system. 100% of these subjects, about 800 subjects reported so far, have a global developmental delay. So the original whole exome did not detect that, the repeat did. Now, it's important, corpus callosum is an indicator for axonal disorders, quality over quantity. Now, finally, some less so obvious facts. Can we suppose which sort of gene or event is behind the callosal disorder? I show you 3 cases, all show a normal corpus callosum, partial callosal agenesis, complete callosal agenesis. Here is the tractography. All these cases look differently. Now, what is the gene? All the same. If you would have looked at the toes or the fingers, you see that the distal phalanges were very small, and this was an ARID1B mutation. Again, about 100% intellectual disability and a very mean low IQ. This was proven also in our collaborators, Jürgen Knoblich, who who grew mini brains out of those patients, showing that the number of connections here was decreased, and also, and here I'm again with the main topic, the quality of those connections. But what about this case? You see that there is a gap. There is the corpus callosum just missing in the midline. If you look at the axial ones, this is a hugely destroyed brain, and you can imagine where this is going. Here we see schizencephalic clefts. If you look at the postnatal MRI, also look at this constellation here in the midline. It's very interesting. It's kind of sulci coming together, and this missing corpus callosum right here. This was a very interesting case because this was a twin transfusion case with a highly abnormal placenta and a demised co-twin. Now, this is the final case I show you. Before I stop, and I want to come to this fact, which probably we do not know yet, but which is I find very interesting. This is a case of a fetal brain tumor. You see that at the midline frontal lobe, there is a signal change on T2, dark. It's bright on fluid suppressed sequences. It's very dark on T2 star, so maybe a little bit hemorrhagic or calcified, and bright on T1. Now, on the sagittal, you could see that the corpus callosum was missing here. Now, we were saying, well, this does not really look like a tumor. That could be a very acute ischemic lesion. To confirm that, we called the patient back, and you could see that there is a hole in the brain right there, where we had this signal changes initially. And on tractography, right at that side, you could see that the fibers were missing, so they were basically destroyed there partially. And that confirmed, to my mind, that this was an acquired lesion. This is the postnatal follow-up, again confirming no tumor there. There's just a little bit involvement of the corpus callosum, just less prominent, and an absence of the cingulum because the cingulum was also destroyed here. Now, I show you here 4 other cases. All of those cases have a missing corpus callosum. All of those cases have somehow schizencephalic cleft-like structures here, or some of them have heterotopia, but most of them have changes which Daniela has shown you before in her talk. Some of them have probe bundles, others have remnants of the corpus callosum. So this is an entity which often is referred to in callosal agenesis with an interhemispheric cyst. Here you see the postmortem MRI. This really looks like a schizencephalic cleft. The big question is this a disruption? Here an example of a boy who is doing very well, and as Daniela said, disruptions are often characterized by a more benign cause. Can we use the term callosal disruption? Well, one indication is that the Italian group with Maria Savina stated they looked at these interhemispheric cysts and said they are associated with a more favorable outcome. A more recent paper indicated that the genetic yield in these interhemispheric cyst cases is close to 0. So actually, you are not likely to find anything here. So why not trying to think and explore that further and think about the term callosal disruption maybe as an own entity within callosal agenesis. And with that, and I'm at the end of my presentation. So keep in mind, whatever happens in the hemispheres is also in the corpus callosum. You cannot kind of put those things apart. We should explore the entire iceberg. It's not enough only to say something about the corpus callosum. Always go to the rest of the brain. The score which we developed is one guideline for that, but you can, of course, look at other aspects as well. And finally, I really want to kind of stimulate the discussion if not only the clear-cut cases of callosal disruptions are a matter of debate, but also other ones which we consider to be genetic, but probably we will never find a gene because they are true